Hello, this is a presentation by Caitlin Thibodeaux and Leah Pace about predicting post-induction hypotension through preoperative pupil size.
Intraoperative arterial hypotension is one of the most common adverse effects of general anesthesia, affecting up to 60% of patients. It is associated with organ hypoperfusion, longer hospital stays, and increased morbidity and mortality. Intraoperative arterial hypotension is broadly defined as low arterial blood pressure during surgery. However, due to the complexities of human and surgical physiology, it is beneficial to separate the intraoperative period into distinct phases of anesthesia to accurately predict and effectively treat the causes of hypotension. The post-induction phase is defined as a period after the induction of anesthesia to the onset of surgical stimulation. In this systematic review, post-induction hypotension is defined as a reduction in mean arterial pressure less than 30% or any mean arterial pressure less than 65 millimeters of mercury, lasting for 1 minute or greater during the time from induction through 10 to 15 minutes after intubation. Studies show that predicting intraoperative hypotension, especially post-induction hypotension, remains difficult. Although the two main suspects leading to intraoperative hypotension include blood loss, vasodilation, and excessive anesthetic depth, there are different causative agents of post-induction hypotension. The two main causes of post-induction hypotension are anesthesia-induced inhibition of sympathetic tone and lack of surgical stimulation. In our summary, our review hypothesizes that because the autonomic nervous system influences both hemodynamics and pupillary size, pupil reactivity could potentially be used to predict post-induction hypotension via their relationship within the autonomic nervous system. Autonomic nervous system dysfunction is a common predictor of intraoperative hypotension and post-induction hypotension. To appreciate the association between the previous mentioned variables, risk factors, pupil reactivity, and consequential hypotension, it is important to understand the physiological foundation of the autonomic nervous system. The ANS is a portion of the nervous system comprised of both the sympathetic nervous system and the parasympathetic nervous system, which both control a majority of organ functions within the body, including arterial blood pressure, heart rate, and pupil size. The parasympathetic system maintains homeostasis, while the sympathetic system prepares the body for stress. Parasympathetic activation results in a slowed heart rate, reduced blood pressure, and pupillary constriction for enhanced near vision. Sympathetic activation results in increased heart rate, an increased blood pressure, and pupillary dilation for enhanced far vision. Both the parasympathetic and sympathetic systems join at the vasomotor center in the brain's medulla. The medulla transmits parasympathetic impulses via the vagus nerve and sympathetic impulses via the spinal cord. Under normal circumstances, the vasomotor center continuously stimulates sympathetic vasoconstrictor nerve fibers, which results in a constant state of vasoconstriction in the blood vessels, also known as vasomotor tone. Therefore, patients with sympathetic deficits will have a difficulty compensating for the anesthesia-induced vasodilation. It is important to note that the vasomotor center's control of arterial blood pressure is rapid. Within seconds, the autonomic nervous system can increase arterial blood pressure twofold. Equally, inhibition of the autonomic nervous system can decrease arterial blood pressure to less than half within seconds. It has been shown that anesthesia blocks sympathetic impulses traveling from the medulla to the spinal cord, resulting in a 50 millimeter of mercury drop in arterial blood pressure, effectively hindering the body's normal vasomotor tone. Similar to arterial blood pressure, pupillary function is determined by the interaction between the sympathetic and parasympathetic nervous systems. Pupillary diameter is controlled by the iris muscle. The iris dilator muscle dilates the eye and is equally controlled by the sympathetic and parasympathetic nerve fibers. However, the pupillary sphincter muscle, which is a primary regulator of pupil constriction velocity and the magnitude of pupil constriction, is primarily under parasympathetic control. Assessment of pupil constriction dilation can provide useful data regarding the body's autonomic, parasympathetic, and sympathetic nervous system function. Currently, pupillary response is used in the clinical setting for evaluating the effects of opioids, stroke severity, and brainstem function after cardiac arrest and traumatic brain injuries. Recently, infrared video pupillometry has made many technological improvements that may allow this device to be used as a quantitative autonomic testing tool. It is now being used to assess autonomic dysfunction in patients with diabetes. Knowing which patients are going to develop post-induction hypotension could help mitigate post-induction hypotension before it happens. Because the autonomic nervous system influences both the hemodynamics and pupillary size, pupil reactivity could potentially be used to predict post-induction hypotension via their relationship within the autonomic nervous system. It is known that autonomic dysfunction is a predictor of post-induction hypotension. However, the only generally accepted approach to measuring autonomic dysfunction is heart rate variability, which requires great technical skill and weakly predicts post-induction hypotension. This study aimed to determine if pupillary measurements can be used to determine autonomic dysfunction and predict post-induction hypotension. It is hypothesized that through the assessment of the pupillary light reflex, healthcare providers can more specifically and proactively tailor care for each patient and are more prepared to provide the safest, highest quality patient care. This review included adult surgical patients undergoing elective non-cardiac surgeries. Inclusion criteria included adults greater than or equal to 18 years of age and surgical patients with ASA physical classes of 1 or 2. Exclusion criteria included children and non-human studies. Any method to obtain quantitative preoperative pupillary measurements were included. Measurements used for this intervention included average constriction velocity, maximum constriction velocity, constriction ratio, maximum initial pupil size, minimum pupil size after light stimulation, percent reduction in pupil size, and latency. The primary outcome measures were mean arterial blood pressure and the incidence of post-induction hypotension. Because there are several ways to determine intraoperative hemodynamics, the authors did not exclude articles based on the method of blood pressure monitoring. The authors did not exclude articles based on the type of studies due to the small amount of literature available. The 2 articles included were both prospective cohort studies. A thorough approach was taken to search the literature to find all relevant articles from August 2022 to September 2022 by 2 doctoral nurse anesthesia students. A university librarian approved and ensured completeness of the search terms, utilized databases, and overall search strategy. 6 databases were reviewed for literature regarding the use of pupillary measurements to predict post-induction hypotension. The articles were initially screened by title and abstract. Then, full-text articles were critiqued for inclusion or exclusion using the Joanna Briggs Institute Critical Appraisal Checklist. During this search, 143 articles were identified, and 2 articles met eligibility criteria and were included in the synthesis of evidence. On all databases listed, each category of the research question was searched individually. Then, the results of each individual search were combined to provide an inclusive list of the results. The following search strategy chart was used to facilitate this research.
Now we will discuss results. A total of 2 prospective cohort studies were included. Both studies were small and from Asian countries. In total, there were 140 participants, 75 of which developed post-induction hypotension. To summarize the results, dynamic pupilometer showed that participants with smaller maximum pupil diameter and decreased constriction velocity had an increased incidence of PIH. It's important to note that the studies were similar in their methods of participant selection, patient assessment, monitoring, and medication dosing during induction. Both studies were comparable in their inclusion criteria, exclusion criteria, and sample sizes. In addition, both studies found that older age was an independent predictor of PIH. The rate of PIH was slightly higher in the study by Miyazaki and others, reaching 55.7%, than in the study by Shao and others, which was at 50.8%. The study by Miyazaki found that maximum pupil size and constriction velocity were predictors of PIH. Similarly, Shao and others found maximum constriction velocity was a strong predictor of PIH. Participants with a higher value of MCV had a decreased incidence of PIH. These results are valuable because the magnitude of pupil diameter can be easily measured with the naked eye and without the use of a pupilometer. As suggested by the available literature, maximum pupillary size and constriction velocity are useful for predicting PIH. In both articles, advanced age was associated with PIH, which agrees with current research showing the general deterioration of somatic nerve function and SNS reactivity. Neither study specified the type of elective surgery the participants are undergoing, which can affect blood loss and the range of hemodynamic changes to expect. Examples of surgeries with high blood loss are cardiac procedures, coronary artery bypass grafting, aortic aneurysm repairs, open femoral fractures, and open radical nephrectomies. Patient age can influence the medication's effects, and anesthesia providers commonly alter medication dosages based on body weight and age. As we've seen, the PIH group had a higher average age, so one could reason that the medication regimen altered their hemodynamic response more than the younger non-PIH group. Both studies show that further research is needed to determine whether pupil size is useful in predicting PIH during routine general anesthesia, and if this has any effect on postoperative morbidity and mortality. Because of the high certainty of correlation between PIH and pupillary measurements, the net benefit is moderate, leading to the conclusion that this service should be provided. These articles suggest that preoperative pupillary measurements could be an avenue to predict PIH in the future, but currently there is not sufficient evidence to definitively answer the research question or suggest a change in practice. Low levels of evidence were generated by both articles. Finally, whether or not the prediction of PIH via pupilometer was successful in reducing the incidence of adverse anesthesia outcomes was not mentioned by either article. To conclude, maximum pupillar diameter can be used as a predictor of autonomic dysfunction in PIH in adult patients undergoing elective surgery with an ASA status of 1 or 2. However, future research with more diverse populations and larger sample sizes should be used to determine if pupillary measurements influence intraoperative and postoperative morbidity and mortality. Thank you for listening, and we hope you enjoyed this presentation.